Colleagues, it's obviously lunchtime, and I think the very large attendance at this meeting speaks a lot about our speaker and the topic. RCSI, we're a health sciences institution. We're completely committed to the quality of our programs. Our mission is to educate, nurture and discover for the benefit of human health, and our aim is to establish ourselves as a leading international health sciences institution. Our medical school is one of our core programs, led by our Dean and our Head of School, Arnie Hill. They're about to embark with many Vice Deans, many of whom are here, on a project of a strategic review of our medical school curriculum, taking on board many of the challenges tomorrow's doctors will face, including professionalism, working as part of teams, self-care, preparing them for postgraduate career success, and working in what is currently a broken healthcare system, working hopefully to resolve and improve that broken healthcare system. So we are very pleased and very proud of our alumnus, Dr. Michael Brennan, who's a leading endocrinologist in the Mayo Clinic. He's a proud RCSI alumnus, an enormous help to RCSI. He's a member of our college board, which meets here quarterly. He's just finished meeting this morning. And Michael has in the past engaged with our colleagues Kieran Murphy and others around the whole area of professionalism, and it's been a tremendous help and support to the college. And he's agreed to address us around some of the evolving thinking and issues that are going on in the planning of the Mayo Medical School, which is one we all admire. So without further ado, it's my great pleasure to introduce Dr. Michael Brennan.
Thank you, Carl, for that kind introduction, and it's great to be back at RCSI. I've been a frequent visitor over the years, and I've always been warmly welcomed, so I feel like I'm coming home, even though I did graduate in 1969, but who's counting? I'm here also with my wife, Dr. Rebecca Bond. She's been actually sent by Mayo Medical School to make sure that I stay honest in this presentation, as she herself is a consultant in endocrinology and also is a Mayo Medical School alumnus. So Rebecca, you can keep me on task here. So let me just set the stage for what I would like to do. This is an outline. Is to talk briefly about what has happened U.S. Undergraduate medical education since the Flexner Report of 1910, and talk a little bit about what is the rationale for changes in undergraduate medical education in the United States. And also then talk about the Mayo Clinic education environment, and then go on to the main subjects, which is a review of curricular changes and curricular redesign around blended learning, teamwork, professionalism, and also what is called the science of healthcare delivery, and also the very important topic of promoting student wellness and resiliency, which is something that certainly resonates with me, having struggled in my early training here in ways that too many medical students continue to struggle as they weave their way through the undergraduate curriculum. So, 1910, Abraham Flexner, a teacher, studied medical schools in Germany, the UK, and also throughout the United States, at which that time there were 155, many with very questionable training programs. His recommendations included reducing the number, which occurred down to 31, increasing the prerequisites for admission so that a four-year college education was an expectation for admission, and to train physicians in a more scientific manner and to engage with the medical faculty, mainly in research. And from there, it was the research faculty who really have dominated medical schools in the United States, certainly in the university-linked medical schools. Also to strengthen state regulation of medical licensure. However, about 15 years later, he was beginning to have second thoughts. Despite all of the good intentions, this is a quote, that scientific medicine in America is today sadly deficient in cultural and philosophical background. that the medical curriculum is overweighted with scientific aspects to the exclusion of social and humanistic aspects. Well, nothing changed for almost 100 years. Interestingly, however, Charles Mayo, sitting on the left beside his brother William, the co-founders, and both surgeons, and by the way, both honorary fellows of the Royal College of Surgeons in Ireland, spoke that medicine is both an art and a science, and that both should make appeal to the true physician. And they actually developed medical education at Mayo around these tenets. So, coming up to 100 years of the anniversary of the Flexner Report, the literature was filled with observations, recommendations regarding changes in the medical curriculum. This one from Molly Cook from UCSF, published in the New England Journal, and you can read it. Basically, again, talking about medical education overemphasize scientific knowledge over biologic understanding, clinical reasoning, practical skill, and the development of character, compassion, and integrity. And went on that more emphasis should be placed on the social, economic, and political aspects of healthcare delivery. That we're turning out graduates who know little about the actual delivery of care. And that's what patients need, is for doctors and other allied professionals to understand the healthcare system so that they can deliver on it. Far more so than politicians or regulators who, despite perhaps best intentions, are not equipped to be able to provide the type of healthcare and healthcare systems that patients deserve. Now, a very troubling report came out just about 6 months ago, also in the New England Journal of Medicine, where there were 6 surveys that were combined that looked at the public trust in physicians. And there were 29 countries were subjected to this study. And basically, the first question on the left-hand side of this panel is, the left-hand side is your trust in doctors in your country being trusted. And on the right-hand side is what is your level of satisfaction with your recent care that you've received from your doctor. And some very interesting results came. The United States in the left-hand column ranked number 24, barely beating out Lithuania, Poland, Russia, and I think also Chile. At the top of the list were some of the Scandinavian countries. But look to the right, so the ranking was 24 on the left, but on the right, the US ranking was 3. So patients were happy with the individual care provided by their own doctors, but they blamed the medical profession for not helping to solve the problems attendant a very dysfunctional healthcare system in the United States. And we well know that dysfunctional healthcare systems is not just a US disease. It's too expensive, there's inequitable access, quality and safety failures have been in the public media, widely publicized conflict of interest, on, and as a result, a dramatic decline in the public esteem of the medical profession, and physicians working hard as a result. One of the major contributors with all of this adverse commentary and publicity, morale is at an all-time low, and burnout an all-time high. So, the American Medical Association, in response to this public outcry, sent out an RFA to the 129 medical schools in the United States. And these were the goals: to develop new methods for measuring and assessing key competencies for physicians, to promote exemplary methods to achieve patient safety, performance, and improvement in the patient-centered team care, and also, importantly, to improve understanding of the healthcare system and the healthcare financing in medical training. In other words, turning out more rounded doctors. So 111 medical schools applied, 11 were successful, including Mayo Medical School. And today I'll talk a little bit about what we are doing using this grant, but also, of course, our own resources in order to deliver. This is receiving a lot of public attention, and Cathal, I think you saw this article back in February, and it dealt with the innovations that are sweeping through US medical schools, and it did feature to some extent the medical school, the Mayo Medical School, that is now being in the final stages of preparation to open in Arizona, where we also have a campus. The main Mayo Medical School, of course, is in Rochester, Minnesota. So, Mayo Medical School grant submission. These were the headings. Optimize student readiness for medical practice and lifelong learning through the bulleted items, integration of healthcare and educational systems at all levels, in order to narrow the gap between what is learned in medical school, but what is needed to improve medicine. And also the milestones, flexible progression, and also the very important topic of student wellness and how perhaps it can be optimized. Now, Mayo Clinic is known as a very large clinical operation centered in Rochester, Minnesota, but also with campuses in Phoenix, Arizona, and in Jacksonville, Florida. What is less known is that it really has a three-shield mission, of which education has always, since 1919, been a very important feature. So there's the Mayo School of Health Sciences, who trains physiotherapists, ultrasonographers, and the like, radiographers. There's the Mayo Graduate School that has about 190 PhD doctoral students. The Mayo School of Graduate Medical Education is by far the largest, with currently 1,700 in training in all of the disciplines, all of the clinical disciplines. Then the Mayo School of Continuous Professional Development, which last year was attended, the various courses attended by 125,000 people across the United States and internationally. And then there's Mayo Medical School, that was founded in more recently, in fact 1970. And currently there are 54 students per year. That is about to double with us expanding into Arizona. So in contrast to the size of the rest of the medical or of the College of Medicine, and indeed the clinic itself, it's relatively small. It had, as of last year, it had 4,500 applicants for these 54 places. I'm glad I don't have to compete anymore. And of those, 200 were given interviews, and 75 were offered positions, of whom 54 accepted. So, a word about Mayo. The needs of the patient come first. This is not something that just appears on a billboard. This is something I heard in my first week there, back in the early 1970s. And it's something that's believed in. And it's something that actually patients are aware of. But also, it really is what dominates the discussions in the decision-making forums of Mayo Clinic. Will this new approach, will it benefit our patients? And that usually is what will win the day. Several in the audience have had a Mayo experience, and I think would agree with that. It is a very integrated, academic, patient-focused group practice of medicine. Our physicians are salaried, which gives us certain flexibility. Obviously, it takes away the profit motive. When I was joining Mayo, they said, well, take care of patients, get on with your colleagues. By the way, we're not going to make you a very wealthy man, and they've been true to their word in that. It has a three-shield mission with a very large research enterprise of several $100 million per year. It has an extraordinarily strong culture of collaboration. You always feel there's no competition, rather people are there to help you. And to help you because in so doing, they're going to be helping patients. It is physician-led, not dominated, physician-led with well-trained administrative partners. It's a very good working model. And there are leadership term limits. Our current president and CEO, Dr. John Noseworthy, is in his 7th year of his tenure as CEO, and he will pass the baton another perhaps 2 years to his successor. And there's great support for scholarship. So we don't pay people extra to do things, but what we will do is to give them time to do it well. So if someone is asked to head the clinical practice committee or to head up development or whatever it might be, we would say, well, we'll give you a 0.2 of an FTE or 0.4, whatever it takes in order to do a good job. So that is the currency. It really is time rather than money. So with that, the vision of Mayo Medical School, it's really not too different from the vision of RCSI. It is to educate physicians and physician scientists who will transform the practice of medicine by healing both patients and the healthcare system. In other words, we need to be turning out leaders who can actually make the necessary changes in order to deliver the care that our patients and our societies need and deserve. So the curriculum has been really designed around this goal. And the curriculum, I think, speaks to this pedagogic insight of Branford in the late 1990s, where he pointed that cognitive psychology has demonstrated that the facts and the concepts, all those facts and concepts that we learn about in medical school, that they are best recalled, actually, and put into practice, into service, when in fact they are taught, practiced, and assessed in the context of which they are being used. So this is a very busy, obviously a very busy slide. This is the curricular, 4-year curricular map of Mayo Medical School. And at the top 2 years are up here, then with the various clinical rotations in the last 2 years. Now what you can see over here, after orientation, we have what is called the science of healthcare delivery. And I'll go into that, and you will see the science of healthcare delivery appears in several places across the first 2 years, and indeed through asynchronous learning in the second 2 years also. A notable feature are these selectives, which there are 13 of them in the first year. And these selectives can be chosen. They're 1 to 2 week blocks, self-directed but mentor-guided learning. They can be chosen for a list of options in the following categories. Those who at an early stage would like to start to explore career opportunities in various areas. So they may have an opportunity of seeing what neurosurgeons do, or endocrinologists, or cardiologists, general surgeons, and the like. They would have the opportunity during one of these selectives to work in underserved communities, either in US cities or even within Rochester, working, for example, in some of the charity clinics that are held by various groups. They may use the time to work in areas that they feel that they're falling behind. So it's a certain remedial aspect. Many of them like to explore what might be some research interests and do some research presentations, and many would like to start to enhance clinical skills. Now, another feature, if I can just go back here, of the first year is that from beginning of August, this is the 2015 to 19 curricular map. On the very first day, they begin their clinical training, so that what is called basic doctoring. So in the morning time, they have their, whatever it is, their anatomy or pathology, and it goes through that first year. And then in the afternoon, they begin to learn about clinical skills, as I say. Some of it in simulation centers, some actually, once they develop basic clinical examination skills, they will examine each other, for example, in the class. So it's this very early introduction to the clinical realm, which they really, and I think it's one of the reasons that the numbers of applicants is as high as it is, that Mayo now is becoming known as the place where you can really develop your clinical skills, patient-centered skills, indeed a reputation that RCSI has in the US for excellent clinical training, and which makes graduates very competitive for residency programs in the US. Now, just some brief examples. These three categories of blended learning, science of healthcare delivery, and promoting student wellness and resiliency obviously would lend themselves to an entire lecture and indeed a workshop. But let me see if I can just give you a flavor of what all of these are about. So, blended learning collaboration. The leading group in the United States for developing modules, educational modules, medical and otherwise, is Arizona State University, which is an outstanding institution, which is geographically, thankfully, located close to the Mayo Clinic campus in Phoenix, Arizona. So there is a very, very strong collaboration that has occurred. And basically, the whole theory behind this blended learning is that to kind of have students already have a certain basic knowledge before they enter a classroom, which will facilitate their critical thinking and application when they do become face-to-face with the preceptor, the professor, or the lecturer. So modules, then classroom, modules, then experience, and then there are what are called asynchronous modules and asynchronous activities. And these are pursued, particularly in the four-year curriculum, in the last 2 years. So there are 30 modules that the students have to complete in the science of healthcare delivery. And they do that as they migrate through the second 2 years of their training. So in the anatomy block, and the anatomy is just down the hallway here, your laboratory, then the modules are provided on the day before the class. The content would include not only gross anatomy, but also the corresponding radiological images. So they will actually see CT scans, for example, with all of the key features that are pointed out before they ever show up at class. And then they're here the following day, they gather, and they have a short anatomy and radiology briefing session that is attended by the professor of anatomy, in this case, Wojciech Paulina. You can see him at the top left at the classroom, and also a radiologist. And they take them through what the modules, any questions, etc. They then go into the lab dissection that is next door, which is, and the goal here is active learning while you're actually doing the dissecting, that it is team-based, so that each team has 4 members with a lead, and there is a fair amount of peer teaching and also review of radiological images. At the end of the morning, they all regroup, and the teams stay at their own tables, and then there is audience response questions. And radiology and clinical correlations. And then they are quizzed on various aspects of this. So this is, for example, what goes on in the actual dissection room. All of the cadavers have been CT scanned prior to dissection, and each group then has access to the CT scans of their designated cadaver. And these are all on mobile stations at the end of the dissection table. And the students can then view, they can actually manipulate the multidimensional images during the dissection. And it allows for correlation of anatomical and radiological imaging. They then regroup for the audience response. And the experience with this has been that, first of all, it provides real-time feedback to the team. Usually the team will actually choose the multiple choice question. The team will huddle and decide, okay, how do we want to answer this? You do have an opt-out option, though, in that if you as a member of the team don't agree with the other 3, you can actually submit a minority report, so to speak. It has user identification, which allows for feedback to each individual, and this is all provided on a secure website. The very strong impression, which is actually being studied, is that it does increase attentiveness, enthusiasm, and participation in class learning activities, and that it really does motivate students to read the assigned materials contained within the modules. They do not wish to show up and it become clear that they really have not done their homework. And by the way, this system is very simple to use. Now, as regards teamwork, leadership, and professionalism, as mentioned, the dissection teams, there are 4 members with assigned responsibility to a team leader. And this team leader, if it's 16 weeks, then each team leader has 4 weeks to lead. And there's peer and self-evaluation of the dissection groups. And again, emphasis on team-based learning. And interestingly, they have a Mayo Medical School Wikipedia in which it allows these teams to enter various reports, their student autopsy reports, clinical project reports, so that others can actually have access and can learn from what the other teams have been doing. So, there is then the peer evaluation form. You may not be able to see it, it's in small print. But basically, each member of the team is given 60 points. And to assign to the other 3 who are in the team. You can't give 20 to each. You have to give some priority. And it's based upon how well was the leader prepared for the laboratory dissection and other team assignments to lead the team. Did the individual contribute to the dissection process and the group discussions and assignments? Were they really putting their shoulder to the wheel? We assume that they were in attendance. Was there personal commitment to one of the choices and rights of other team members? And do they have responsibility for their own actions and decisions? So, in other words, many of the things that we talk about professionalism, were they dutiful, were they accountable, were they scholarly, were they helpful, were they respectful, all of these things in the very earliest weeks are beginning to be scored, evaluated and scored, and all of this is then part, in fact, of the integrated grading system. And you can see up to 30% of the final grade for anatomy is based upon laboratory peer assessment score. So this is taken very, very seriously by the students. Moving on, science of healthcare delivery. We're all familiar with the basic sciences and the clinical sciences. What has been lacking, in the opinion of many, is that we haven't been preparing students for systems science. How do we act, in the case of healthcare, how do we actually deliver all of the knowledge, all of the insights that we've gained, how do we actually go about delivering that to the benefit of our patients and to the benefit of society? We chose this at Mayo because we felt that we could build upon this culture of collaboration as well as innovation. If you're going to build a medical center that now has 40,000 employees in a town of 110,000, in the middle of nowhere, in the middle of cornfields, you have to be innovative. You don't have all of the infrastructure that you would have in a major city like Boston or New York. So innovation has been the lifeblood of Mayo Clinic, and it continues to be. And there is this sense of this is something we have to do if we're going to be successful. There are also great opportunities for students to add value as they go through their curriculum. Many of the students will say, you know, I'm just the recipient of all this learning. I wish I could roll up my sleeves and kind of become, even at this early stage of training, that I could start to do something that might actually benefit patients, assuming that I'm appropriately supervised and prepared to engage in that, and I will touch upon that in a moment. So this is our vision at Mayo for the science of healthcare delivery. It is, as you can see, and again, it is to train students to work in teams, to be patient-centered, also to have a sense of what is meant by population health, and have this to be science-driven, and also have an understanding of what we mean by high-value care across the healthcare system. Now, to do this, you need collaborators. I've mentioned ASU, that has been very helpful has been in the lead of developing these modules, including modules in the science of healthcare delivery that I will speak about in a moment. We also have been working with the Dartmouth Center for Healthcare Delivery Science, which is another leader in the United States in this area. We also take advantage of in-house, so we have what is called a Quality Academy. And also we have an Office of Population Health Management at Mayo. And in addition, Mayo Clinic has what is called the health system, which is across 3 states in the upper Midwest, including Iowa and Wisconsin. And these are clinics and hospitals of various sizes that give us the opportunity for our students to go out and to work in more rural areas, to see how healthcare is actually delivered away from a large academic medical center, and to better understand what are the challenges out there for doctors who may be working in small groups or indeed in solo practice, although the latter is a dying breed. Now, the curriculum, briefly, the approach to this was to determine what are the domains that are needed, and I'll speak to those in a moment. There were 6 domains that were identified, and they were value and quality, population care, teamwork, leadership, individual patient care, and policy, law, and economics of medicine. So we identified the domains and then did the gap analysis. What would we need to develop in order to be able to deliver on this across the curriculum? So there are 6 teams, each with responsibility for one of the domains. And again, it's co-led by a physician leader working with an expert in one of these areas, either from ASU or from Dartmouth or from Mayo itself. It is intended to then embed this across the curriculum. It does not take away time from what I call the organ system block times. So it lives throughout the 4-year curriculum. And it is a mix of synchronous, in other words, the module that you're studying today is of relevance to the face-to-face discussions of the day, or it can be asynchronous, of which there are 30. And these are things that the students are expected to complete during their 2 years. They get 6 months to complete each of these and to submit their reports and to take a test to see indeed if they have achieved a level of mastery. By the way, this does lead to a certificate level diploma at the end of their medical training. The plan, however, is to expand this into a full master's. This may take an extra year working at ASU, but we're working in order for graduates to have both an MD as well as a master's in the science of healthcare delivery. And this is becoming a very attractive feature in graduate medical education as well. So we feel that if we can prepare students at this level, that they will be able to take advantage of those centers that are taking the science of healthcare delivery at a graduate level seriously, that they already will have had at least a certificate, but in the future, master's training in science of healthcare delivery. And these are the modules that I have spoken about. So these are the domains as I have mentioned. So, for example, at the top, high-value care. Well, what the students need to understand, what do we mean by high-value care? Well, it is really outcomes over cost. What are the outcomes of the care? What did it cost to deliver that outcome? And obviously the outcome includes, did the patient get better? Did the patient have a serious complication? Was there some sentinel event? Was there some serious thing that happened? So to start to get a sense of the value concept in medicine, also taking advantage of evidence-based medicine, and then to the right, going in a clockwise direction, population-centered care. So to have a sense of what are these health disparities that are major in the United States, as I'm sure you're well aware. How do you actually engage not only to treat disease, but how can you actually be a leader in promoting wellness and health promotion in your communities? To learn more about what are the determinants of health within groups, and to provide culturally sensitive care. For example, some of this would be done in the Salvation Army Clinic, where the students will actually work with a volunteer physician, a Mayo physician within the Salvation clinic within Rochester. And they would actually talk to patients. What are the issues, what are the things that are preventing you from gaining the kind of health that you would want for you and your family? Getting a sense of that, where really the rubber meets the road, rather than just writing prescriptions and waving farewell, but to really get a sense of what does it take. And then team-based care. This would be working in collaboration with nursing, with radiographers, with others. For example, care transitions. How do you actually prepare a patient to go from hospital back home, hospital to nursing home, hospital to clinic, whatever it might be? And what is the work that is needed to ensure that that is a safe passage that the patient would have, recognizing that oftentimes patients are dismissed from hospitals and either they or their families are ill-prepared to take over the care. So how do you actually prepare that? And also the collaboration with interprofessional teams. And when you have interprofessional teams, you're obviously going to have some tension among the groups. And how do you actually manage that? How do you learn to be able to work in that type of environment? In the area of leaders, and we believe that turning out doctors, should really be turning out the leaders of the future healthcare delivery systems. I think that's true in the United States, and I think it's also probably certainly desirable here in Ireland. So what about learning something about change management and how leaders can motivate groups? Because physicians in the rather hierarchical academic medical centers do tend to be the leaders. Working with individual patients about shared decision making. We're no longer there just to tell the patients what to do. We need to come up, we need to learn the skills necessary in order to partner with their patients, because the data clearly shows that patients who feel they have co-created their ongoing care are far more likely to remain compliant with it. Individualized care, that it is not, while we do have evidence-based medicine, but we also have to have individualized care, because some patients, one treatment modality may not be workable for their work life or their finances or their family situation or wherever it might be. Understanding better community resources and also being patient advocates. That's really what we want our doctors to be, is to be advocates for their patients if we really are going to deliver on meeting the needs of our patients. And how would they learn that? Well, the medical students, for example, are assigned, they meet with an elderly person, some would say on Medicare, in the community. And they have 6 meetings in the first year, where they will actually even go to the patient's medical appointments. They may actually go with them to their pharmacies. They may actually go with them shopping to see what are the challenges that they face in trying to comply with the nutrition guidelines, for example, that have been provided. Again, it's the real life of the patient, not just something that is lectured about. And then as regards healthcare policy and economics, healthcare technology, these are the various categories in that particular domain. And again, each of these domains would justify an all-day workshop or more, but this is just to give you a sense or a flavor, as I said, of what it's all about. So if we just take, for example, a look at the curricular map again. So as you can see, the top left-hand corner is the 1 week of orientation, followed by 2 weeks of the science of healthcare delivery. And what happens during that period of time is that the domain leaders, first of all, they receive their modules the day before the formal sessions, and the formal sessions are conducted by the domain leaders. They then go on after, so they're now into December, and they've had 4 selectives behind them at this point, as well as their anatomy training. And they're into areas of patient advocacy, informatics, and health equity. They learn, for example, how to interpret epidemiological databases. And for example, Rochester is located in Olmsted County, and there is the Olmsted County database where we can track every individual, and that has provided great insights into the natural history of disease and how it evolves. So included in that database would be everybody within Olmsted County who smokes cigarettes. So this allows then to go to the next level when the student would be learning about, it's called oxygen, it's actually the respiratory system. And they learn about what are the criteria for lung cancer screening. There's a big NIH project underway that Mayo is a participant in, looking at should we be doing CT scans on patients with smoking histories and the like. And obviously, doing these scans carries with it always the risk that we're going to find little nodules, and then what do you do about that? Are they benign? So in order to learn what are the pros and the cons of this, they need to have an idea of what are the desirable criteria for lung cancer screening. And then role-playing in negotiating with patients on research use. This is in the last block of the first 2 years. And this is about role-playing, negotiating with patients on research use. Many patients in the US system, given that they're not going to be paying a lot out of pocket for those who have insurance, so they want the latest. If you don't do a CT scan or you haven't done an MRI, even though I've had a cough the last 4 days, what kind of a doctor are you? And there's no point saying, I'm just not going to do that. It requires this ability to negotiate, ideally, because if you refuse, the patient will go on to someone else, and they'll do it. So it requires this, being almost a teacher of our patient, an educator of our patients. But this requires certain skills, and these skills are required. And again, this is supervised by oftentimes nurses, but sometimes physicians, to help in this role playing. And then as they get into their various clinical rotations, and you can see how these are broken down, 6 weeks blocks in medicine, surgery, pediatrics, and on and on. And then we talk about this shared decision making with patients meeting the criteria for lung cancer screening. And this is where the students actually, having received the necessary training, will actually sit down with these patients and talk to them about lung cancer screening. What are the actual benefits that may be for the patients? What are the things that they need to know about before they would enter, for example, this study? And then on to population health. And this is a very interesting one. It's called a checkbook. So that during their rotations in the hospitals or clinics, they were able to track the team that they've been on. We're able to track what have been the expenditures on tests and treatments during those various blocks. And then for the students to be able to, taking advantage of the knowledge that they've now gained in the economics of medicine and value, the value equation, they're able to look back and say, yeah, maybe that CT wasn't necessary, or maybe we didn't need CT plus MRI. So they're beginning to become, they're made aware of what the costs are of the care that they have been engaged in, and hopefully leading to a greater understanding, because basically medical residents and students who are with them go around with an open checkbook in many American hospitals. And that has to end. So, on to the last category of promoting student wellness and resiliency. I think we're doing okay for time. You're all familiar with Maslach's burnout inventory. That is well accepted. It is now stood the test of time for maybe 50 or more years. It entails this sense of emotional exhaustion, which measures feeling of being emotionally overextended and exhausted by one's work. Depersonalization, that sense of unfeeling and impersonal response to the recipients of one's service. Not exactly what you want to have in your doctor, right? And this sense of personal accomplishment, the sense of low accomplishment, feelings of measures of feelings of competence and successful achievement of one's work. So these are the parameters. And Sadly, burnout and suicidal ideation among US medical students is at quite a high level. In fact, this study from Lottie Derby and her colleagues at Mayo and several other medical schools across the country, burnout was in the past 6 months was reported by almost 50% of students, and 11% reported serious suicidal ideation. A very, very alarming statistic. What about, do they enter medical school stressed? I mean, we've all heard about the helicopter parents in the United States, and we've heard about, young students being snowflakes that they melt on when exposed to any kind of heat. In actual fact, it probably is true that young American students, there was a survey done, and they think, well, what age do you think you actually reach adulthood? And they say, about age 30. I mean, they're still talking to their parents about what courses they should take in medical school or others. So there is this tremendous dependency that has grown up that is really the parents are responsible for, probably. But in any event, that is as it is. However, the matriculating, those entering medical school, are they at a higher burnout rate or distress rate than others entering other programs? Well, this survey would suggest not. That in fact, the findings, along with the high rates of distress reported in medical students and residents, supports concerns that it is the training process and the environment that contribute to the deterioration of mental health in developing physicians. So what can be done? Well, this is actually a study that Lottie Derby and her group at Mayo published in the Journal of Graduate Medical Education a couple of years ago. It looked at the ability among residents of a physician well-being index to actually identify residents who are seriously stressed. It's a 7-item survey which has been shown to be a useful screening index to identify residents whose degree of distress may negatively impact the quality of care that they deliver. And in fact, there is a very strong link, proven link, between student and resident distress and burnout and poor quality of care. They make more mistakes and the like. So very undesirable. Now the LCME, the Liaison Committee on Medical Education, says, well, every medical school must have a student wellness program. But they don't really provide any guidelines of the format or the content. They just go do it, do something. And basically no proof of efficacy. So what I think is, this is the work, in order to overcome student distress, it is the work of both the organization, of the medical school, of the hospital, or whatever the setting is, that there are certain things that will predictably increase student stress. One is a grading system that results in intense competitiveness between the students. We no longer have a grading system at Mayo. And Darcy Reed, who visited here with me last year, has published on the results of the results that came about having discontinued the grading system, that the students are doing just as well on UCMLE and all of the other tests. So a grading system is not actually helpful in allaying some of the fears and distress that students have. I think what is called curriculomegaly, that appeals to an endocrinologist, right? That this is also a factor. And it is why we have at Mayo these selective times for students to catch their breath, to actually go back and to work on the things that they decide they really need to be working on, and that will encourage, that gives them the opportunity of having a certain degree of autonomy over their student days. This competitiveness that exists in many medical schools is very, very destructive. Poorly structured clerkships is a source of student distress. They know that they have to learn a certain amount during that fairly condensed period of time, and then they're maybe working with teachers or consultants who have little time for them, or worse, are engaged in student abuse, which we know is rampant unfortunately, in hospitals in the United States. And these clearly are things that every organization has to take responsibility, that students should not be exposed to teachers who will humiliate them rather than help them to overcome some of the challenges they face. And also there is the sense that, and I think this is very true, that once the students get into the clinical areas, and particularly in the United States, if they really are, you know, those snowflakes, all of a sudden they're confronted with the human domain of illness and the impact it has not only on the patients but on their families. And for many, that is a whole new experience in life. These are often individuals who have sailed through their schools at the top of usually coming from very well-functioning families. They're at the top of their class in school. They go to college and they're all the A students. That's how they get into medical school. And then when they're in medical school, all of a sudden things change. Everybody's an A student. And now in addition, they're meeting some of the challenges of ill patients working in very dysfunctional healthcare systems. So our AMA grant, the third aspect of this, was working on to try and study what can help with student wellness. So you have an advisory program, I believe, here at RCSI. We have one. We also have a year one longitudinal resiliency curriculum that I will refer to in a moment. And then we have an online medical student wellness index, similar to the one that actually it has been adapted from the one that Lottie Derby and her group have developed. And looking at what are the benefits of this? Well, a study looking at the multi-institutional study exploring the impact of positive mental health on medical students' professionalism in this era of high burnout. And what Dr. Derby found and her colleagues suggests that positive mental health attenuates some of the adverse consequences of burnout, and that medical student wellness programs should aspire to prevent burnout and promote mental health. This is an example of the Medical Student Wellbeing Index that students can fill out on a monthly or 6 weekly basis. And these are the questions that they're asked. It's very, very simple. 7. And it then comes up with a composite score, and students are encouraged that, in fact, if they appear to be heading in the wrong direction, that resources are available. And it will actually point to them. If it's in an area of fatigue or stress or depression, it will actually push them in the direction where the resources are most likely to be of benefit to them. And the students are taking advantage of this in great measure. So the resiliency, what we call it, the toolbox that is being developed, there is the well-being index, and by the way, this has been validated in a longitudinal individualized self-assessment, and as I've mentioned, it is linked to just-in-time resources to aid medical students. The new advisory system, there are modules, and face-to-face wellness and resiliency training and self-care education. And there is the year one longitudinal small group facilitated wellness. Now, in orientation, that first week in the top left-hand column, is the orientation. And what is spoken about is you're now in medical school. You can now expect that this is going to be a stressful time of your life. You're not alone in that. You don't have to feel that if you speak up and share your concerns, that in any way is going to impact your successful career here at this medical school. In fact, your failure to do so will probably result in your having a more difficult time in navigating. And I think that is something that the students they feel very reassuring, that I'm not alone in this. And by the way, it's okay to speak up. In fact, it's not okay not to speak up. And when you feel that's needed. The photograph is of Dr. Ahmed Sood, who has written extensively on wellness and resiliency, both in the medical realm and outside. He's a general internist at Mayo, a wonderful man. He actually talks to the students in one of those early days of orientation. And he actually talks about what is the prevalence of stress in society and what are the factors. He actually tells the interesting story that he came from an area of Bhopal, which was that place that there was the dreadful chemical accident 20 or 25 years ago, where there was something like 10 or 15,000 people died and others were poisoned. And he said it was so dreadful, and the stress level among doctors as well as in the population was unimaginable. And he said, when I had the opportunity of coming to America, I thought, this is going to be Disneyland, right? But he says, I came to America and I find people even more distressed than they are back in Bhopal because of the pace of life and the demands, etc. So he points out that there's a very high prevalence, not only among doctors, but he talks about what are the precipitating factors that they need to look out for as they traverse the medical school curriculum. And what are the adverse personal and professional impacts? And he talks about this is not being weak, or this is not being not up to it, but rather what are the neurophysiological underpinnings of stress? We know increasingly, we read about the plasticity of the young adult brain, and that in fact our musculoskeletal maturation maybe is completed 20 or whatever it is, but that we continue, our brain development continues to mature. There may be some neuroscientists in the audience who can put me right on that or help me with that, but I understand that it is now generally accepted that during those years when our students are learning to become doctors, that in fact they're still developing as people from a neurological and neuroscience and psychological standpoint. He talks about the strategies overview and the available resources. Down on the right-hand side is one of his books on the top is called Stress-Free Living. Now, this is a medical student who's been up all night studying, has gone through anatomy class, and this is the medical student leaving the medical school at that time. Unfortunately, that's not the case. So, the wellness group discussions, this is an interesting approach. Basically, they have a number of themes, and they break into, these are held on a regular basis throughout their first year. By the way, it is mandatory, but they are provided with a nice lunch. There are 12 to 14 students in each group with doctorate level facilitators, the wellness coaches and the like. And basically, they have various themes that they discuss. So Monday might be, as they're going through their various activities on a Monday, think about the theme of acceptance. On a Tuesday, it may be compassion. And then they all get together and they begin to share their insights on these various themes, about gratitude, about relationships, about giving up, what can I not change and what can I change? And these are very, very rich discussions. And as the year progresses, you see this bonding of the students and all of the insights that they gain. Generally, the groups remain the same throughout the year. Sometimes there have to be adjustments made if they're on other assignments and the like. There's tremendous student engagement in all of this, and the feedback so far is that it is extraordinarily helpful to them. So I'll end here. I want to acknowledge the people who actually do a lot of this work. Dr. Darcy Reed, who is no stranger to RCSI. She spent several days here last year engaging with many of you in the audience. She's Associate Dean for Academic Affairs. Alex Walensky is Associate Dean for Student Affairs. Steph Starr is co-director for the Curriculum of Science Healthcare Delivery. Lottie Derby, whose publications I have spoken about, is a professor of medical education. And Susan Romansky is Director of Curriculum for Basic and Advanced Doctoring. And they all know I'm here today, and they all said they'd be very happy to join you here at RCSI if you would like more detail. So thank you for your attendance.